Thank you, Ed. And this is my first time using this Steve Jobs' invention. So since I'm technologically challenged, you'll have to bear with me. I have no conflict of interest. The only equipment that I'll be talking about are light and electron microscopes. And before we look at the objectives, I'd like to just give you a brief overview of what you can expect today. The lung is a very complex organ. It's composed of airways, alveoli, and blood vessels. And all of these, when they develop, have to develop in intimate concert with each other. They have to appear at the right time. And for the organ to function normally when the infant is born, all of these processes have to occur just right. So you can well imagine that when so many of us are born with normal lungs, the control mechanisms that are involved in the growth of each of these structures is extremely tight. But every once in a while, they go awry, and then we have developmental disorders. So the objectives for today's talk are, first of all, to learn the developmental processes that contribute to the lungs, airways, air spaces, and vessels, and then to understand the functional implications of disordered lung development. So these structures grow under certain laws of lung development, and I'd like to go over those laws in a moment. Law 1 has to do with the development of the airways, the bronchi, and the bronchioli. And I don't know if it's a well understood fact, but all of the airways that we have are developed in the first 16 weeks of intrauterine life. After that, there are no more airways formed. What are formed are air ducts and alveoli, but all of the airways that we have for the rest of our lives are formed in the first 16 weeks of intrauterine life. So that means that if there's any aberration that affects the growth of those airways, it must act within those 16 weeks. The second law has to do with the growth of the alveoli, and it indicates that when we are born, we have about 20 million alveoli. By the time the lung has completed its growth, we have 300 million alveoli. Those additional alveoli form largely postnatally. So whereas airway growth is an intrauterine event, alveolar growth is a largely postnatal event. And the third law has to do with the growth of the arteries, and it states that the preacinar arteries appear at the same time as do the airways, which means very early in gestation, whereas the intraacinar arteries develop at the same time as do the alveoli, so they appear largely postnatally. So here's a graphic demonstration of what occurs. You can see in the canalicular, in the glandular phase, it's largely airway development. Then in the canalicular phase, the cartilage and glands form, and between 24 weeks of gestation and term is when the alveoli, or the saccular phase, occurs. And then postnatally is when most of the alveoli are formed. And this next graph, diagram, indicates how, I thought I had a pointer here. Somebody said if I pointed, it would appear as an arrow, but it doesn't seem to be doing that. So right up here at 16 weeks, you can see that the acinar structure is a very simple structure, but you can see that as time progresses, as one goes up to about 7 years of age, you can see that the acinus increases as you go inferiorly in that diagram. So next, let's look at the blood vessels. And on the left, you can see what a normal vascular structure would be. The white area represents muscle within the vessel wall in the media of the vessel. And you can see that as you progress from the hilum to the periphery, that the muscle disappears from the vessel wall, and the more peripheral vessels are non-muscular. In any condition where that process of muscularization is accelerated, one has muscle appearing more and more peripherally in vessels that normally should be non-muscular. And you can well imagine what this would do to the vascular compliance. It would increase the resistance of those vessels, and that is the clinical condition that you're probably familiar with, namely persistent pulmonary hypertension. So in the diagram on the right, you can see that such a process has in fact occurred, and that more peripheral vessels have muscle in their wall, and that would be a condition of persistent pulmonary hypertension of the newborn. So the density of these muscular, partially muscular and non-muscular vessels is shown here in the fetus, the child, and the adult. And you can see that if in the fetus you have a condition that actually should occur much later on in life, you would have a situation where the vascular resistance in the pulmonary arterial tree would be markedly increased, and that is a condition of persistent pulmonary hypertension. And you can see in this diagram that normally in the fetus at term, the muscle in the vessel walls stops, in the media, stops at the level of the terminal bronchiole. And as you progress further on in life, until the muscle progresses in more and more peripheral vessels, so that in the adult, in that last bar at the bottom, even vessels in the alveolar wall have muscle in their wall. But if that process is accelerated and in a precocious manner, the muscles have the vessels have muscle in their wall, that would have a significant physiologic impact on the infant. Now, there are two different types of pulmonary vessels. The ones that branch dichotomously with the airways are called conventional arteries, and those are depicted in red. I think it's red in the diagram there. But you can see that there are a large number of blue vessels, and those are the ones that arise at right angles to the main axis, and they supply the alveoli that are right around that particular arterial tree. So there's a large number, many more supernumerary vessels, which are the blue ones, than there are conventional vessels. And nature's got a particular reason for this. It is the mechanism whereby we who are all sitting here at rest right now could get up and run a marathon and not get totally out of breath and go into failure. It is because of the recruitment of those supernumerary vessels. So at any given time, only a small percentage of the supernumerary vessels are actually transmitting blood to the air spaces. Most of the time they're shut down, and there's a sort of a pulsatile mechanism whereby these vessels open up, and they can be recruited when we need to increase the blood supply, such as with exercise. The other important point to note is that there are drugs that can selectively target the supernumerary vessels, and so they are a very useful phenomenon that can be employed to alter lung function with the use of medications. So those are the basics of lung growth, having to do with the airways, the alveoli, and the blood vessels. And as I said, the control mechanisms are extremely tight, but every once in a while they go wrong. And what we'll do next is examine examples of disordered lung growth. And I think a useful way to to understand these different disorders is to consider them in terms of growth and maturation. The lung is an interesting organ in that one doesn't just have to have the structures in place, but the structures have to undergo a biochemical maturation in order for the lung to do its function of gas exchange. So we'll consider the developmental disorders of growth and maturation, and I'll just go over some examples to show you how a disorder of one of these can manifest with a lung aberration. We won't be touching on acquired and other disorders today. So disorders of lung growth, here's a list of the more common events that you might encounter. And we're not going to obviously go through all of them, but just touch on a couple as an example of disordered lung growth. And these have to do with disorders of airways and alveoli. Disorders of blood vessels manifest with a few different conditions, and we'll look at examples of these as well. And then finally, there are disorders of maturation, and here's a list of those disorders. And once again, the one on top having to do with prematurity and surfactant lipid deficiency, I think you're all very familiar with it, and that has undergone a sort of a metamorphosis with the advent of surfactant replacement. So I think most people are very familiar with that, but congenital alveolar proteinosis is a relatively rare condition, but extremely interesting, and we'll look at an example of that. So to turn then to the disorders of lung growth, one of the conditions is a hypoplasia or aplasia, where the lung just fails to grow in size. And here are some of the causes. And the causes, as you can, if you go down that list, have to do with conditions that reduce amniotic fluid, which is extremely important for normal lung growth. And all of these, renal agenesis, renal cystic disease, and obstruction of the lower urinary tract, all of those contribute to amniotic fluid through the fetal urine. So anything that reduces fluid will cause hypoplasia of the lungs. Premature rupture of membranes will also do the same thing. And then skeletal dysplasia is a condition where the space for the growth of the lung is reduced because of a skeletal abnormality, and the chest wall is, the chest cavity is small, and so the lung has no place to grow. So how does one analyze lung hypoplasia? Well, one rough poor person's way of doing it is lung weight, and we define hypoplasia as a lung that is less than 50% of the normal expected weight. Another good way of assessing it is the lung weight to the body weight ratio, and a ratio of less than 0.012 meets the definition of lung hypoplasia. And if you go down that list, you can see that reduction in the number of airways, in the number of alveoli, in the number of air-blood barriers, and the number of intra-acinar arteries, all of these will contribute in some one way or another to hypoplasia of the lung. So I'd like to give you an example, a clinical example of a child with lung hypoplasia. This was a term baby with multiple congenital anomalies, and because of these had a do not resuscitate status. The infant had Dandy-Walker anomaly and had a congenital diaphragmatic hernia with a number of abdominal organs present in the thoracic cavity. And here you can see on the right a hypoplastic lung. That was the ipsilateral side of the diaphragmatic hernia. So the space for the lung growth was markedly reduced, and therefore the lung failed to grow. And we used a mechanism that we used to to illustrate the vascular abnormalities in the lung at autopsy, and that is a barium angiogram, and here's an example of it. And you can see that not only was this lung reduced in size, but the vessels are extremely abnormal, and they're not just abnormal on the ipsilateral side, but also on the contralateral side. So what you're seeing here is marked crowding of the pulmonary arterial tree on both sides and a reduction in the branches, which gives rise to a pruning effect, just like you prune the branches of a tree. So here these vessels are pruned and they failed to form. So that's an example of hypoplasia or aplasia of the lung. And the next example I'd like to discuss is that of congenital pulmonary adenomatoid malformation, or what we call CPAM. So before we look at an example of that, I'd like to show you this diagram, which on the left-hand side, the top left, shows the growth of the developing lung bud. And as it develops, it is enveloped in a mass of mesenchyme. And at that growing tip, there are intimate epithelial mesenchymal interactions that occur. There are messages being transmitted from the epithelium to the mesenchyme and back again, which actually dictates how this lung bud should grow and branch and proceed in its development. So you can see in the lower diagram at the lower left, there's a portion of that developing lung bud that got detached from the growing tip and is growing by itself. And that's an example of bronchial atresia, where the connection between the growing bud fails to be established. And in the extreme right-hand corner, you can see that there's hashed marks at the growing tip of that lung bud. And that is an example of what would happen if those epithelial mesenchymal messages get scrambled. So that's the sort of thing that could cause a congenital pulmonary adenomatoid malformation. And in this example, you can see that the disorder can occur during the growing phase of the airway or the alveoli, and depending on the timing of that insult that causes the scrambling of the messages, one can get different patterns of disordered lung growth, and they manifest in different types of adenomatoid malformations. And the different pathologic features are depicted here. So for example, in number 1, which is the most common type of CPAM, type 1, you can see that represents about 65% of all of the CPAMs that you might encounter. And if you look at the next column down, or the next row down, you can see that the size of the cysts is very large in type 1, whereas in some of the other types, they're much smaller. So the object of this is not to teach you how to examine or how to classify each of these adenomatoid malformations. It's merely to show you how such a malformation can occur, but more importantly is to impress upon you the importance of the timing of the insult, because timing, in addition to the actual dose of the growth factors, is critically important in lung growth and development. And depending on the timing, one has a malformation with a different pathologic pattern. So here's a diagrammatic representation of some of these different types of CPAMs, and you can see the type 1 has the very large cysts, the type 2 has smaller cysts, and the type 3 actually looks like a solid glandular structure. Type 3, by the way, is extremely rare. So here's a chest X-ray you're probably all familiar with, and that's what one of these CPAMs would look like on plain imaging, and here's a CAT scan image of it. And in this next picture, one can see such a CPAM that's been resected, and you can see the little light structures that represent the cysts with very thin walls. And then microscopically, here's what the cysts look like. They are thin-walled, they have a little bit of fibrous tissue, and they're lined by flattened cells. that you can see in the lumen of the cysts. Now, in the type 1, some of those cysts might have mucinous epithelium, and on the left side you can see such mucinous epithelium, and the red stain on the right is a mucicarmine stain that actually labels the mucin in that epithelium. So here's the next example that I'd like to show you of congenital lobar emphysema, which is, again, something that you all must have encountered. And here's what the chest X-ray of such an infant would look like. Most of these are on the upper left, in the upper left lobe, but this happens to be an example on the right. And you can see the resected specimen here of a congenital lobar emphysema. And here on cut section is such a specimen. Notice that if you resected normal lung, the atmospheric pressure would cause the air spaces to collapse, and one would get what looks like a solid structure. But in congenital lobar emphysema, if you recall that initial resected specimen, it was still inflated. And that's a typical example of what happens with congenital lobar emphysema. The air spaces are enlarged and they fail to collapse. So here's a comparison, and which of these would you think is the normal and which one is the abnormal section of lung, based on what I just told you? Pardon? So the one on the left, is that the normal one? No, that's the lobar emphysema. The one on the right is the normal lung. So the way to distinguish them is you should not be able to see air spaces with the naked eye on cut section. And you can see the air spaces on the left. So that's the congenital lobar emphysema, and it tells you what is the prime problem here, which is marked increase in volume of the individual air spaces. And as these increase with increasing age, the lobe of the lung inflates to where it occupies the entire thoracic space and compromises respiration. The reason for that is that there are these pores of Kohn that communicate between air alveolar spaces, and these pores favor inspiratory filling but not expiratory emptying. So with every breath, more and more air gets trapped in that lobe until it severely compromises lung function. So those are a few examples of disordered airway and alveolar development. And before I go on to vascular abnormalities, are there any questions about what we've talked about so far? Seeing none, we'll turn our attention to abnormalities of lung vessel growth. And the first example is that of persistent pulmonary hypertension of the newborn, a condition that is frequently associated with meconium aspiration syndrome. And in such a condition, there is precocious muscularization. If you recall, when we talked about normal lung vessel development, the structure of the vessel is critically important. And if one has precocious muscularization of more peripheral vessels, that will contribute to an increase in pulmonary vascular resistance. So in this diagrammatic depiction, one sees on the left-hand side the normal vessel in relation to the airway. And you can see that the yellow part, which represents the muscle, stops at the level of the terminal bronchiole, and that the more peripheral vessels are either partially muscularized or totally non-muscular. On the right-hand side are examples of structural abnormalities in the pulmonary vasculature that correspond to the clinical condition of persistent pulmonary hypertension of the newborn. So I'm going to show you some examples of this because I'm sure you've all encountered patients who have PPHN. Some of them are placed on ECMO and they then come off the ECMO and do perfectly well. whereas others, despite every maneuver that you try, the patients succumb. And I think I can give you an understanding of why some do better and some do not, whereas they all have pulmonary hypertension of the newborn. So here's an example of a 3-day-old boy that was transferred to our hospital from Tucson. And the infant had respiratory distress and persistent pulmonary hypertension. He was transferred for ECMO, but expired before it could be initiated. We did an autopsy, and here is the barium angiogram. And what you see here is the vessels are extremely small caliber, and they have a reduced number of branches. So clearly, something went wrong in the vascular development of this child's pulmonary arterial tree. So we're going to take a little detour now to try to understand what are the processes that are involved in the forming of a blood vessel. And our understanding begins with some studies that were done in the chick embryo, where people studied how vessels are actually assembled. And there are two basic processes whereby vessels form. One is angiogenesis, which refers to the sprouting of vessels from pre-existing vessels. And the second is vasculogenesis, which refers to the formation of vessels from blood lakes. And these two different mechanisms whereby vessels are assembled, I think are important in the pulmonary vascular tree context, and I'll show you why via some studies that we did to better understand this. So here's a diagrammatic representation showing angiogenesis on the left and vasculogenesis on the right. Now here's how things get a little complex because I've got animation, and I'm not sure how this will work with Steve Jobs' invention here, but I don't know what I'm supposed to do. Okay, it's all shown up, all right. So this is not obviously to confuse anybody, but just to impress upon you that the formation of a blood vessel, it may not look like a very complex structure to you on naked eye exam or on microscopic exam, but it is an extremely complex procedure involving a large number of transcription factors and growth factors, all of which have to act at the right time in the right dose. Any derangement of either of these can result in extremely abnormal outcome. So to better understand what of these processes were involved in the formation of the lungs vasculature, we undertook a study, and we sicked it on this unsuspecting medical student who wandered into the lab and wanted to do research. And you'll see why, because his job was to study the lungs vasculature in these mice embryos. And just to impress upon you the complexity level, we've compared the size of the embryos in which he was to do this study with a green pea that we got from the hospital cafeteria. And you can see that he had a very difficult job indeed to do. What he had to do was, once again, the animation. He had to inject into the developing pulmonary vascular tree of these mouse embryos a resin called Mercox, which is a useful tool to use because initially it's very thin and permits injection into the vascular tree, but upon exposure to the atmosphere, it undergoes hardening and it's very tensile, so you can manipulate it. And our idea was to use a combination of transmission electron microscopy and scanning electron microscopy to study these vascular casts in the developing mouse embryo at different stages of gestation to try to elucidate or determine which of these vascular processes that we've talked about are involved in the formation of the lungs vascular tree, whether all of them, both of them, or one of them, and which one contributed to which component of the vascular tree. So here's what Devin Sawyer had to do. And you can see in this next transmission electron micrograph that at 9 days, the growing lung is made up of a mass of mesenchyme within which a few little spaces begin to form. And then these spaces, by about 10 days, have primitive hematopoietic cells form within them, and you can see that the structure of the plump mesenchymal cells at the periphery of these spaces undergo attenuation and assume the morphology of endothelial cells. Here's an example of the vascular casts in these mice, and you can see that at about 13 days of age on the right-hand side, the primitive vascular tree is beginning to form now. And in these next images that are scanning electron micrographs, you can see what the peripheral portion of the lungs vasculature at 13 days looks like. There then begin to form little buds that connect the peripheral vascular tree, and by 15 and 16 days, these fetal mouse lungs vascular casts assume increased complexity, as you see here. And in close-up view, you can see how complex those structures begin to form. Here's another example at 15 days, and you can see how the most peripheral vessels now have a very fine caliber and an increased complexity that is the mature pulmonary vasculature. So from this study, we concluded that both processes, angiogenesis and vasculogenesis, are involved in the development of the lungs vasculature, and that at some stage there's fusion between the proximal and the peripheral, the angiogenic component and the vasculogenic component, so that the circulation then is established. So the next order of business was, well, all of this is good and dandy in the mouse, but we're dealing with humans. What happens in the human? Are these same processes involved, or are they different? And you couldn't do this study that we did in the mice, obviously in the human, but we did the next best thing. And before we talk about what we did, I'd like to acknowledge the contribution of several people whose foresight and vision made that possible. So on the left, you have Andrew Carnegie, who instituted the Carnegie Institute in Washington, where the contribution of Drs. Moll and his are housed. And what they did is from the 1800s and 1900s, they had embryo collections, and they contributed that to this Carnegie collection of human embryos that are housed in Washington. And the value of this collection is that human embryos, the entire human embryo from different gestational ages, are completely sectioned and stained, so that if one wanted to study the origin, the course, and the ending of a given structure of interest, in this case, the pulmonary vascular tree, one could study these various stained slides and actually map out the course of these structures. So my mentor, Professor Lynn Reed, and I went to Boston and studied hundreds of thousands of these human embryo slides. And I'm just going to show you a couple of examples. Here's one from a 32-day embryo, and you can see the arrows are pointing to the developing trachea and esophagus, and the black arrows are pointing to little structures that represent vascular lakes. that are forming at this stage, stage 14 in human embryo development, at a time when there are no blood vessels accompanying the trachea or the bronchi, the developing bronchi. And then at 50 days, one sees the airways, the two big structures in the middle of the field, but the arrows are pointing to a vascular network that is out in the primitive mesenchyme surrounding this developing airway. And again, at this point, there are no vessels in proximity to the developing airway. So there's a vast network occurring peripherally, but as yet, the proximal vessels have not presented themselves. And then at 54 days, now one sees a vessel in accompaniment to the developing airways. So what we're getting at is, in this telescoped view of this study, which actually took quite a long time, that there are two different components to the lungs vasculature. The peripheral one that contributes to the intra-acinar vessels, and the proximal one that contributes to the pre-acinar vessels, and that in the human as well, there are these two processes, angiogenesis and vasculogenesis, and that at some point in development, there is a fusion between the two vascular components so that the circulation is established. So once again, we've seen this picture before. The next question was, well, what are the mechanisms that control these processes in the development of the human arterial tree? And we chose to study one of these growth factors, namely vascular endothelial growth factor, for a number of reasons. It is one of the best studied angiogenic growth factors. It plays a critical role in stimulating vessel growth. And previous studies had shown that deletion of even a single VEGF allele was lethal to the developing embryo. So it suggested that it must play a very important role in the development of the lungs vasculature. So we elected to study this in a VEGF knockout model of a mouse. And I'm going to skip through this in the interest of time. You can see that VEGF in the mouse has different isoforms, VEGF 120, 188, and 164. And these different isoforms occur because of alternate splicing of different exons. So if one knocks out exons 6 and 7, one gets the VEGF 120 knockout mouse. And we got these mice from colleagues in Boston, and in these mice we did the very same study that I've already shown you in the normal mouse, and studied the Merck's vascular casts of the mouse embryos. The VEGF genotyping was done to ascertain that we indeed had knocked out these other two isoforms. And here's an example of an entire mouse embryo, a mouse vascular cast, a whole body cast, Merck's cast in a mouse. So in these mouse embryos from the VEGF knockout mouse then, we compared the wild type mice with the heterozygous and the homozygous, which means both alleles were knocked out. And in the subsequent images that I'll be showing you, look from left to right, because on the left will be the wild type or the normal mouse. In the middle will be the mouse with one normal allele and one deleted allele, and then on the right will be the one with both alleles knocked out. And what you will be comparing is the density of the vascular casts and the caliber of the casts as you go from left to right. So here at 15 days, you can see that the homozygous mouse on the extreme right has a very small cast compared to the wild type on the extreme left, and the one in the middle is intermediate between the two. And here on high mag is the comparison of these casts once again, very scant in the knockout mouse on the right, and a higher MAG yet at 15 days, showing that the wild type has a much finer caliber and more dense cast compared to the homozygous. And then in the 17-day-old, you can see compare the density once again, very dense on the left in the normal mouse and very scant on the right. And here at high MAG, again, less dense on the right in the homozygous VEGF knockout mouse. And then at 18 days, the same feature. And on high MAG, once again, on the right-hand side in the knockout mouse, marked paucity of vascular cast. And then finally, at the 1-day-old mouse, you can compare the density from left to right. And here on high MAG, you can see that the homozygous knockout at 1-day-old has a very scant vascular cast with less dense vessels. And then microscopic exam of these mouse lungs were also of great interest and actually highlighted a very important feature, namely that the air spaces in the knockout mouse were markedly reduced, depicted by those red asterisks. You can see much fewer asterisks on the right compared to a large number in the normal wild-type mouse. And this phenomenon was also seen by transmission electron microscopy. You can see a nice sized airspace in the wild-type mouse and practically no airspace in the knockout. So what this tells us is that those two isoforms that we knocked out were critically important for lung airspace development, and that knocking them out actually severely compromised lung airspace development. But even more important than that is this next feature that we noticed, namely the presence of air-blood barriers. And here I must point out that this perhaps is the single most seminal event in lung development, namely the formation of the air-blood barrier. What happens is right at the air vessel interface, there is fusion between the basement membrane of the endothelial cell and the basement membrane of the epithelial cell that overlies it. And that fusion is the air-blood barrier. And this should be of prime import to you all who deal with respiration in the newborn, because it is across this membrane that gas exchange occurs. And this is the single event that permits all of us to be breathing air here at rest. And this event occurs in every air-breathing mammal. Failure of the air-blood barrier to form is a fatal disease, and I'll show you an example of that. It's got to have a very tight developmental control because it is such a rare event. So it's rare that it actually doesn't occur. But in these VEGF mice then, you can see that the air-blood barriers failed to form. You can see on the left, large number of these air-blood barriers, and you can actually see the dark structure in the one at 9 o'clock on the left is a red blood cell within a capillary at the air interface. And on the right, you can see the air-blood barriers failed to form. So we did some morphometric studies and showed that there was a statistically significant difference between the formation and the number of these air-blood barriers in the homozygous or the knockout mice compared to the wild type. So that tells us that even these individual isoforms are of critical import in the formation of this structure that is so critical to air-breathing mammals. So we concluded then that the absence of these isoforms impairs development of the lungs microvasculature and develops airspace structural maturation. So getting back then to our PPHN patient, after that little detour, there are different patterns of abnormal vascular structure that correlate with the clinical condition of pulmonary hypertension. And so the type 1 that you see there is maldevelopment. And here's an example of such a maldevelopment in a 41-week infant who had marked hypoxemia, respiratory difficulty shortly after birth, was treated with mechanical ventilation, nitric oxide, ECMO, but succumbed at 2 weeks of age. So let's take a look at this infant's lungs, and you can see here that his barium angiogram and autopsy was fairly, the pre-Asner vessels are not all that abnormal, but examination of the microscopy showed, better in this next slide, that there was a marked degree of smooth muscle in his smaller vessels, more peripheral vessels, and that he had an abnormal structure. So this is an example of the type 1 pulmonary hypertension of the newborn, in which there is maldevelopment and abnormal vascular structure. And we think it's a reference or an example of aberrant angiogenesis. And this type is unlikely to respond to therapy because the vascular structure itself is abnormal. So type 2 would be an example of maladaptation. So when the infant is born and takes its first breath, the lung obviously expands, and with the expansion of the lungs, the vascular tree expands. And we call a condition called compliance, which is, I guess you can compare it to a tenderizer effect on a piece of steak. It increases the vascular compliance is increased with the first breath. And that's a normal event. It reduces the pulmonary vascular pressure that is present in fetal life. When that adaptational process fails to occur, one can have persistent pulmonary hypertension. Those are the infants that when they're placed on ECMO, it gives them time for that normal mechanism of adaptation to kick in, and then when they come off of ECMO, their vascular resistance has reduced and they do well and go home. So I don't have an example of that, obviously, to show you, because those are the ones that are successful. So type 2 PPHN is where the vascular structure is normal, but the absence of the postnatal increase in pulmonary vascular compliance is the cause of the hypertension, and this type is most likely to respond to treatment. And then we'll look at an example of type 3. This infant was born at 30 weeks gestation, had gasping respirations at birth, was unable to be ventilated, and died in a few minutes. We take a look at this infant's lungs, and you can see that the line is actually an example of radial alveolar count, how we do a radial alveolar count, which is to drop a perpendicular from the terminal bronchiole to the pleura and count the number of alveoli that line intersects. So the radial alveolar count in this infant was normal, which tells us that the airway and the alveolar development was normal. We looked then at the blood vessels, and you can see here, normally in cut section of a lung, one should have a 1-to-1 ratio in the diameter of the blood vessel to the airway that it accompanies, because the arteries travel with the airways in a bronchoarterial sheath. So there should be a 1-to-1 ratio in cross-sectional diameter. And you can see that the proximal arteries are of normal caliber. But when you go out to the more peripheral vessels, notice what's happening to the size of the arteries. They're much smaller than the airway that they accompany, and that gets even more significant when you get out into even more peripheral vessels. So you have these pinpoint arteries compared to the size of the airway. So here's another example of it to show you that this was not just an isolated event, but it was diffusely present throughout this infant's lungs. So this infant then had hypoplasia of both the pre- and the intra-acinar arteries, and precocious muscularization, so that more and more peripheral vessels had muscle in their wall. They had thick media and adventitia, and this infant also had interstitial emphysema. So I ask you then, would this be an infant that you would expect to rescue from its persistent pulmonary hypertension? Not likely, because of the structural abnormality in the vessel wall. And here's an extreme example of such a hypoplastic arterial tree. The only possible etiologic factor we could find in this mother's history was that she had cocaine use during pregnancy. So type 3 persistent pulmonary hypertension is an example of structural abnormality and failure of growth of the pulmonary arterial tree. In other words, underdevelopment of the vasculature. And this type is not likely to respond to treatment. So next I'd like to talk about this very rare condition, but it's of import because it is an example of what is so critical for normal air-breathing mammals, namely the formation of the air-blood barrier. When it fails to form, it is reflected as this unusual condition called alveolar capillary dysplasia that is accompanied by malalignment of the pulmonary vessels. And here's an example of such an infant. Was born at 36 weeks gestation with hypoxemia and apnea shortly after birth, was placed on ECMO for 2 weeks, could not be weaned, and died at 2 weeks of postnatal age. This condition is uniformly fatal. And here's this infant's lungs at autopsy. And here's an angiogram of the infant's lungs. And you can see on the left is a normal pulmonary arterial tree. Notice the caliber of those vessels and compare it to this infant's angiogram on the right. You can see that the vessels are pruned. They have very few branches. And the background haze that is contributed by filling of the pre-capillary segment of the pulmonary arterial tree is absent in this infant's lungs. And then when you look at the microscopic exam of the lung, you notice on the left the artery and the airway are up in the upper left-hand corner, and the vein travels at the periphery of the lung lobule in the pulmonary septa. Whereas on the right, in this infant's lungs, you can see the artery, the airway, and the vein all traveling in the same arterial sheath. So the veins are misaligned, and on closer exam of the peripheral portion of the lung, you can see that the air-blood barriers have failed to form. Notice the barriers in the normal lung, all identified by the arrows, and in this infant's lungs, there are no air-blood barriers. The vessels have failed to migrate up to the alveolar surface, and so there's no air-blood barriers, and obviously gas exchange is compromised. And that same feature is seen by electron microscopy. So here's an example of alveolar capillary dysplasia, and recently studies have shown that the whole structure, the formation of these barriers might be under the control of the FOX gene, because they've found deletions of some of the alleles, some of the exons in this gene that have been present in patients with alveolar capillary dysplasia. So I'd like to go then in the last few minutes to an example of disordered lung maturation. And this is of interest to us because we described the first case of surfactant protein B deficiency in St. Louis several years ago in a family that's kind of interesting, because the same two parents had, well, let me back up first. So the infants with surfactant protein B deficiency develop respiratory distress, right, shortly after birth, and it is a fatal condition as well. And here's an example of such a child. This newborn developed severe respiratory distress shortly after birth, did not respond to conventional treatment, underwent a lung biopsy, and died shortly thereafter. There was no autopsy done, but here's the lung biopsy, and you see on the upper left-hand corner that the air spaces are filled with an amorphous eosinophilic material, and we stained this lung for surfactant protein A, surfactant protein B, and surfactant protein C. And you can see that there was no SPB staining in this infant's lungs, but there was SPA and SPC. And then northern blots were done and compared to the lungs of other infants with other conditions, but not surfactant deficiency. And you can see in the SPB row that this infant had no message for SPB, so the RNA was missing as well. And on Western blot, you can see that the protein was missing. The arrow points to that site. So here's this infant's lung chest X-ray, and on the right is the pedigree, and the index case is indicated with an arrow. But what I started to tell you was what was of interest in this case was the same two parents that had this child had had a sibling to this child born 20 years earlier. And it's a good thing that pediatric pathologists are pack rats and they never throw anything away. Because when we got this kid, we went back to the archives and pulled out the lung that the sibling had an autopsy done, and the lung blocks were still available because we never throw pediatric material away. And we got the lung blocks from the archives and stained it, and that child had died of the same condition. And that simple phenomenon, or that simple exercise, enabled us to identify this as a familial disorder. And subsequently, the gene was analyzed, and we found that there was a mutation in one of the codons, 121, and a simple amino acid alteration is what resulted in this surfactant protein B deficiency. So subsequently, across the world, lots of other mutations have been found in the SPB gene, but the one that we identified is a common mutation that's present in about 3/4 of these patients. So this is it's a rare condition, but I wanted to describe it to you to indicate and as an example of disordered lung maturation and how a single gene defect can cause dysfunction of the entire organ and claim the infant's life. So to recap then, we have examined developmental disorders. We've looked at the different processes that contribute to the structures of the lung, the airways, the alveoli, and the blood vessels. We've looked at disorders of growth and of maturation, and the impact that they can have on the newborn infant. I thank you all for your attention. And